Velkommen til Rig på Viden, en podcast om forskning i investering, finans og økonomi. Mit navn er André Thormann.
Hello and welcome to the first joint episode of Rig på Viden and Econroots. Very exciting. I am Stefan Sløk. I am very delighted to be honored with the task of now also co-hosting some episodes of Rig på Viden. So thank you very much for that honor. I work at Copenhagen Business School and at Cepos, and for today's episode and to provide relevant Danish insights, I am joined by a co-host today.
Yes, that's me. I'm Karsten Bo Larsen. I'm research director here at Cepos, and I am heading our work on healthcare. But the real star of this program today is Michael F. Cannon, who's here to talk to us about U.S. healthcare economics and policy. And we will be focusing on Michael's recent book, Recovery, a guide to reforming the U.S. health sector. We also have a short competition relating to that book, so stay tuned.
Yes, and before we hand it over to Michael with the first question, I'll just like to introduce you. So Michael F. Cannon is the Cato Institute Director of Health Policy Studies. His scholarship spans public health, regulation of providers and drugs, employer-sponsored and other private health insurance, federal programs like Medicare and Medicaid, medical malpractice litigation. Wow, that was a tough one. Wow. Hope my old English teacher is not listening to that. Administrative law, and finally, international healthcare system. Cannon is, and I quote, an influential healthcare wonk, according to the Washington Post. And the Washingtonian magazine named Cannon one of DC's most influential people in the last 4 years. Wonder if you get that honor this year as well. Let's see. He has also appeared on numerous, and way too numerous to mention, international news outlet. He is originally educated at the University of Virginia and George Mason. And I think I met you the first time at Cato U back in 2007, maybe. So we actually go way back, but we haven't spoken in 10 years. So,
right.
Yeah, but anyway, you taught me a lot back then, so I'm sure you will do as well today. Welcome to Denmark, Michael.
Thank you. Thank you for having me.
Cool. So let's get right into it. What is at stake in U.S. healthcare and what is going wrong?
Oh, God, so much. So much is at stake and so much is going wrong. What's at stake are lives. Our ability to get effective healthcare to as many people as we possibly can and to improve the quality of their lives and save their lives. And also our ability to stop providing them healthcare when it is not improving their lives so that we can devote those resources to something else. And we are not doing a very good job on either of those scores. We make healthcare in the United States exceedingly expensive. There's no reason that prices have to be as high as they are right now. And the reason they are so high is because of massive amounts of government intervention that seems like its purpose is to increase prices as much as possible and channel as much of U.S. GDP to healthcare providers and health insurance companies as possible. And what that then does is it not only prices health insurance and healthcare out of reach for a huge chunk of the population, but for those who do have healthcare, for those who do have health insurance and purchase medical care, they pay much higher prices than they need to pay. They consume much more medical care than they need to. That soaks up so many resources that could be improving human lives even more if we devoted them to housing or education or other priorities, many of which would improve health more than they would if, the way we're spending them right now. So the what's at stake, it really is a matter of life and death. And we've sort of been failing that test. There's a lot that the United States does very well when it comes to healthcare, particularly developing new medical innovations, which end up saving lives in the United States and saving lives elsewhere. But we fall down when it comes to making those innovations affordable and driving down health prices, medical prices, in order to make healthcare more universal.
Okay, interesting. Before we move on with that, oftentimes the U.S. system is contrasted to the Danish system, Karsten. So how many of these issues do we know here in Denmark
A lot of them, actually. We are also very good at producing new cures with medicine. The Novo Nordisk is a brilliant case, but we also have a lot of problems in our healthcare sector. We also have a huge overproduction. The OECD estimated it is around 20 to 30%, and it's a pure public system. So it seems that some of the failures in healthcare are similar, even if you have an insurance-based system or a pure taxpayer finance system as we have in Denmark.
Interesting. So similar challenges. Now, according to many people, Michael, even respected sources like The Economist, the US healthcare is completely left to the free market, right? But you mentioned government a lot. So please enlighten us here.
So this is the most persistent myth that you encounter when you debate healthcare in the United States or have debates in other countries that involve the United States. It's that the U.S. health sector is the most expensive in the world, and they have a free market. So that must be what free markets produce, and so we don't want to emulate that. We don't want markets in healthcare. And that's just completely wrong. Mm-hmm. In the United States, government plays as strong a role in healthcare as is in any other advanced nation. In fact, when the OECD looks at the share of health spending that consumers control, which is a precondition of a market economy, mm-hmm. that the consumer controls the money, versus the share that the government controls. So that share serves not the preferences of consumers, but the preferences of government or politicians or special interests or whoever controls those decisions. When you look at the share of health spending that is compulsory, the United States has one of the highest shares among OECD nations. It's 85%. That is 2 percentage points less than the number one country, Germany. That means the United States is in a tie with France, Czechia, Denmark, and Norway. So government has as much control over health spending in the United States as it does in Denmark. And Denmark has this single payer, well, not quite single payer, but this universal government run system. How can this be? It turns out, and that share, the 85% share in the United States is larger than the shares in the United Kingdom and Canada, which also do have government run single payer universal systems. How can that be? Well, the United States doesn't just have socialized medicine or efforts at universal healthcare. We've got every variety that every nation has ever invented in the United States and some that no nation has ever invented. Half of the US population has health insurance through an employer. That is compulsory health insurance, not unlike the German system. There are some dissimilarities, yes, but that is an important similarity. About 1/6 of the U.S. population has health insurance through a system like the Canadian system or like the Danish system, where the national government sends money out to states in the case of the United States, or regions in the case of Denmark, provinces in the case of Canada, and then those states, regions, provinces administer a universal system where there's no out-of-pocket payment, where healthcare is completely, I'm using quotation fingers here, free. There are dissimilarities, but that's a pretty significant similarity. We also have our own version of the British National Health Service. We call it the Veterans Health Administration. It covers about 1% of the population. That's U.S. veterans of the U.S.
people.
Military. But it is something that very few nations have, which is a fully integrated health care and health insurance delivery system, where all of the doctors and all of the hospitals and all the clinics and all the nurses work for the same entity that owns the hospitals and so forth. So our Veterans Health Administration is just an American version of the British National Health Service, and it doesn't even stop there. We've got the equivalent of the Dutch or Swiss system in or what we call the individual market, or Obamacare at this point, which is heavily regulated private insurance with price controls and all sorts of other regulations that make the quality of insurance worse, but that covers a significant chunk of the population. Then we've got our own unique homegrown version of socialized medicine, which is the U.S. Medicare program. And this, gentlemen, this thing is special. This program enrolls 66 million people, so 11 times the population of Denmark. And it is a system where the national government just controls everything, where it determines what the coverage will be, what the coinsurance will be, what the prices will be for individual services. And it sets all of those prices itself. It is this massive effort at centralized planning that is so sweeping. The U.S. Medicare program is the largest purchaser of medical services in the world, at least if you measure by dollars spent. And no other nation has a system that matches it. And then just for fun, we put some people in both the Medicare program and our version of the Canadian or Danish systems, the Medicaid program. So they have coverage through both. But then we've also got, but still, when people look at the 8% of the US population that does not have health insurance, they still, with all of that government intervention that gives the government control over 85% of health spending, they still say, oh, well, some people in the United States don't have health insurance, and in a free market, some people would not have health insurance, ergo it must be a free market, ignoring all of that came before. So what's actually happening with the uninsured is all of those other government interventions, from the tax preferences for employer-sponsored insurance to the subsidies in Medicare and Medicaid and Obamacare, what they all do is they drive private prices higher. They drive private health insurance premiums higher, and they make it harder for that 8% of the population to afford insurance. So that's a measure of government intervention and government failure, not an indicator that this is a free market.
Really interesting. So I like to go off on a little side note here, because I like history, and very briefly, Danish healthcare, and please correct me if I'm wrong, Karsten, used to be pretty private, and then the government took over most of it. Now there's an element of private left still. All these programs, how do they come about? Why are you stuck with so many different programs?
Oh, that's a fascinating story. It all happened by accident.
All right, yeah.
It all happened by accident when Congress passed the second federal income tax in the United States. The first one happened as a result of the Civil War.
Yeah.
So the Union could raise money to defeat the South and defeat slavery. And thank God they did, but they let it lapse. They let that income tax lapse, and it was glorious that they did. But in 1913, Congress created the second federal income tax. And at the time, there was no such thing as health insurance. So not as we know it right now. So Congress never gave employer-sponsored health insurance a thought. But when the question arose, should the Treasury tax compensation in the form of health insurance or any form of health benefit that employers provide, it was actually a really complex question. And the bureaucrats in the U.S. Treasuries just threw up their hands. They said, we don't know how to tax it. We're not going to tax it. And that right there set in motion a series of events that has led to every other government intervention that I've mentioned.
Wow.
What that did was it encouraged employers to provide health insurance because you could give them compensation tax-free. It encouraged people to buy more health insurance than they would otherwise. So that made them less price conscious when they were purchasing medical care. That caused prices to rise because providers can charge higher prices when their consumers are not price sensitive. The higher prices caused more demand for health insurance, and so more demand for employer-sponsored health insurance. And you got this cycle where prices kept rising and rising. And then Congress began doing things to try to help people afford this healthcare that it was making so expensive. And the worst part, so there are additional tax incentives that Congress created that just made prices rise faster. So it would be tax-free, but prices would rise faster. But the worst part was that Congress inadvertently tied this tax preference to a form of health insurance that disappears when you leave a job. Oftentimes, now that is a terrible reason for your health insurance to disappear. So every health insurance policy in the United States that covers 50% or more of the US population is terrible health insurance that the government is forcing people to buy. You will lose your health insurance in the United States if you turn 18 or 26 and become an adult and are no longer covered under your parents' policy. If you divorce, if your spouse dies, if you change jobs, if your employer just drops coverage, if the plant closes, if you get so sick you can't work anymore, if you retire, all of these reasons you can lose your health insurance. And ever since Congress started compelling people to enroll in employer-sponsored insurance, it has passed subsidy program after subsidy program to try to fix the problems that Congress itself created. So one example, and then I'll stop. In 1965, Congress created the U.S. Medicare program to cover retirees. That was about 40 years after Congress began penalizing people unless they enrolled in a form of health insurance that kicks you out when you retire. So they started compelling people. In 1965, there were health insurance companies, lots of them, who would sell health insurance that covered you from cradle to grave into retirement. But Congress forced people into health insurance that drops you when you retire. And then it looked around 40 years later and said, why do all these retirees have no health insurance? We had better create new government subsidies. And so they did. And those subsidies further drove up the price of health insurance, the prices for medical care, just making this problem worse and worse.
Wow. Yeah. So, Karsten, was the US an early adapter, or if we compare it to the Danish history, what do you think here?
What I first and foremost think when I hear Michael telling the story is that it sounds a lot like the Danish rent control system. We had rent control for some apartments, and we couldn't abolish that because then it would hurt those people living in those apartments. And as we know, it's also always harder for a politician to hurt a small group, because they easily organize and can make a lot of noise in the press. And the beneficiaries of abolishing the rent control was all the people who couldn't get an apartment. So you try to fix that with another law and another law and another law, and then you have a total mess. And it sounds quite like that. We have very different history in Denmark for healthcare. As you said, it started as something that was similar to an insurance system. You went down and you bought your health insurance. It was when my parents were young, actually. It was like that. But then it was overtaken by the Danish welfare state in the 50s and 60s. And then we have this almost total public system. A lot of Danes now is buying private health insurance, but they're only covered about 2.5% of the market is private now. So there's not that much activity financed by private insurances, but it's rising. And the reason for that, at least as I think, is that we are suffering from the Maltese cost disease. Many Danes want to buy more healthcare, actually, but they can't do that because they have to buy it through the government, through taxes. And we have one of the highest tax pressures in the world in Denmark. And if you increase that even further, it will have huge consequences for the incitament to work and establish a company and so on. Actually, we are not are probably on the top of the level curve. And then what to do if you want to buy more health insurance? So it's a quite different story, but with the one similar thing, that people can decide for themselves how much health they want to buy. So that's a similar problem.
Mm-hmm. You might be on the other side of the top of the ladder.
Yeah.
45% of GDP is that we're talking about right now? Yeah.
So one thing, getting a little bit back to the prices that consumers then pay, healthcare and particularly drugs is some of the hardest thing for a normal person to have any grasp of the fair price of, obviously, because there's very little competition, obviously, and it's hard to figure out, nobody knows how expensive it is to make a drug, basically, unless you are a pharmacist, right? So one thing we often hear is these horror stories about people being ruined by the prices of drugs in the US. To what degree are those set by market mechanisms? So the prices that people actually pay at the pharmacy?
So that's a really good question because in the United States, there are no explicit price controls on drugs holding down what private drug manufacturers can charge for their products. So again, a lot of people look at the U.S. health sector, they say no price controls, must be a free market. But that completely ignores, again, the entire history that I've laid out of government intervening in the financing of healthcare, because every one of those interventions drives up the prices of pharmaceuticals. And even there are even some that I haven't mentioned already, but the employer-based health insurance system, as well as the Medicare program and the Medicaid program, and likely the Obamacare or our managed competition market, drive up drug prices by making the consumer price insensitive. So they will not switch to a lower price drug because they don't see the savings. If their insurance company or if the government tries to switch them to a lower price drug, they will complain and the employer or the politicians will back off. And there are also regulations that drive up the prices of drugs by in addition to the effect of subsidies. So, and one that I've done some research on is the Affordable Care Act, or Obamacare, required that starting in 2011 and taking full effect in 2014, all private health insurance companies had to cover all prescription contraceptives at 100%. So there would be no price sensitivity at all. They would be free contraceptives. Prior to that regulation taking effect, insurers did require some form of cost sharing, co-payments or co-insurance if you wanted to buy prescription contraceptives. And as a result, because of that, and because there are lots of contraceptives options, there's competition and price competition, the price for hormones and oral contraceptives was falling in real terms relative to inflation. It was falling. This is good. This is how we make healthcare and contraceptives more universal. But as soon as that regulation requiring 100% coverage of contraceptives took effect, those price reductions reversed, and prices for hormones and oral contraceptives doubled over a 9-year period. Because, and this is a correlation, not causation, but it is reasonable to surmise that the producers of these products said, you know what, our customers are not price sensitive anymore. So we can raise our prices and we'll see how much we can get away with it. You know, they don't really know. And we'll be able to get higher prices out of the insurance companies because they are not as good at negotiating lower prices as consumers are.
This is a horrible story, right? Because we are talking about a form of drug here that I'm guessing fairly generic, like relatively cheap probably to produce and stuff, and yet we see prices going up, which is completely opposite of what we normally see in a free market, where prices tend to fall as the learning curve rises. And
what we did see in the United States, even though we didn't have a free market, but we had just a modicum of competition and price sensitivity, and we still saw prices coming down, and we then outlawed that.
Horrible. Do you have something to add here?
No, not to that topic.
Because then, because I do think people don't realize how complex the pricing of drugs are, even in a universal payer system like Denmark. I mean, I personally take a drug for something I have in my throat, and if the hospital will give it to me, it's free, but if I have to buy it at a hospital, it's 3,000 Danish crowns. So, I'm stuck with you. Do you want to go to the hospital and spend an hour, or do you want to spend this ridiculous amount, right? And they can't really explain it to me either, the professionals either. So even in a universal payer system, I mean, there's so many differences into how we actually price drugs. Yeah. Yet the US is always blamed for somehow having the worst system. And I think that's fairly unfair, right? Yeah.
So there's similarities in the US Medicare program. I can't think of one regarding drugs, but one regarding cataract surgery is that the US Medicare program will pay a hospital $2,000 to perform a cataract surgery, and it will pay an ambulatory surgical center $1,000 to do it on an outpatient basis. Exact same procedure. No need for the patient to be in a hospital when they're getting that procedure. And yet the Medicare program still pays twice as much in that setting versus the ambulatory surgical center. It makes no sense whatsoever. When you have a government bureaucracy that is purchasing medical care, they are going to be the ones determining what the prices are. They're going to be, through whatever mechanism, spitting out prices, and those prices are almost always going to be wrong. Now, prices are often wrong in a market system as well. But in a market system, there are forces that always are pushing the price in the right direction, so that the only reason you're going to see a price differential like cataract surgery in the United States or your your drug in a hospital versus purchasing it outside of a hospital is if there's some economic reality giving rise to that, if the underlying costs are different. It doesn't sound like the underlying costs are different in a hospital. In fact, it sounds like the underlying costs would reverse.
Exactly.
It should be cheaper outside of a hospital than in,
Definitely.
but because the government so often gets the price signals wrong, you have people wasting resources by going into the hospital to save themselves some money when it ends up costing the taxpayers a lot more. That's just a pure waste. And because you don't have those market forces or the invisible hand of the market always pushing in the direction of the correct price or the market price, those pricing distortions remain, and you get waste year after year, but you also get shortages year after year where the government sets the prices too low.
Exactly. And I think this is very interesting. I'd like you to comment a little bit on this, Karsten, as well, because I'm trained in transaction cost economics a lot and done research in that. And one of the main questions that is always make or buy. That's the main strategy decision. Should you make this or should you buy it somewhere else?
Yeah.
And I think one of the issues with the Danish system, and then afterwards you can comment if that's the same in the US, is that in the Danish system, because it's a universal payment system, it's not just the hospital, it's also the roads, it's also the schools, it's also all those things. So you never get somebody to just focus on, how do I make the most optimal make or buy decision for this hospital or these kind of treatments, because they're part of a way bigger budget and the whole thing. Is that sort of the issue that's at stake here, Karsten?
There's been a lot of focus on the expenditure for medicine on hospital, because it's rising and rising and rising at the Danish hospitals, and it's a big problem. I worked a lot with that when I was working at the Ministry of Finance, and I think one of the problems is the demand side. Because it's free to get every kind of most kind of medications in Denmark and most kind of treatments. So the demand is infinitely limitless from the patients, because they don't have to pay for that. That is the case for the taxpayers. And so we have all kinds of committees trying to prioritize, should we use this drug or shouldn't we use this drug? What is the cost-benefit analysis and so on? And it just doesn't work. Then should you make or should you buy? Of course, a lot of medicine can't be made in Denmark, and we have to buy on the international market. And a couple of years ago, the Danish pharmacist was a monopoly. But that has been a big liberalization who made the non-prescription drugs prices fall dramatically. But the prescription drugs are now, what can you call it, oscillating up and down, because the pharmacists are forced to using tenders. And sometimes there's a lot of medicine on the market, sometimes there's no medicine on the market. So people having taking medicine that they have to get, or less they die. Sometimes they pay around $2 for the medicine, and sometimes they pay around $600 for their medicine, and it's pure lottery when they go down to the pharmacy and say, I'm ran out of this medication. Can I get some new? And then they have to close their eyes and see what is the price. So it's not working at all. And I think it's actually the demand side that is it's not working. It's hard to getting to work. Also in a system like the Danish one.
Interesting. Do you guys think, and feel free to jump in, either of you here, is it a bit of a political illusion that to have government so heavily involved and thereby creating even more supply problems in healthcare? Is it an illusion that politicians are selling the electorate?
An illusion
that the market would be better, that they would be better served with government intervention than without it. Because in Karsten's example here, and you also mentioned shortages from government purchasing and so on, it seems like a more free market would be able to regulate supply better, right? Whereas if you have all these weird schemes and so on, you would create artificial shortages and thereby actually making it worse for the patient.
So I would call it maybe myths rather than illusions.
All right, yeah.
Because there are, just as there are myths about whether the United States has a free market in healthcare, there are myths about how a free market operates in healthcare. Those myths include the myth that health insurance markets, without heavy dose of government regulation, will fail due to adverse selection. Well, that's not quite true, because in the United States, there were, until 2014, small and very lightly regulated markets for health insurance in most states. And these markets were sustainable. They provided secure access to medical care for people after they got sick, and guaranteed that those people could keep paying not sick person premiums, but healthy person premiums. And that market was remarkably innovative. It even was innovating in the direction of filling in gaps in the employment-based system that government created, so that when you lose your job, you could still have health insurance. People that the government was just dropping, the market was trying to help. But in 24, and there could have been further innovation there, but the market, or what government did in 2014 is they outlawed that market. They outlawed all of that innovation. And they did it because most health economists believed this myth that that a free market cannot provide secure access to care for the sick via health insurance. And that myth is, you could say that myth is now law, and it is a real tragedy, because there is evidence from the United States that actually markets do remarkably well. And so it's by the creation of lots of these sorts of myths that they are able to claim this power for themselves and destroy the evidence. Mm-hmm. They are, when you outlaw these sorts of markets, you don't get the innovations that disprove the myths. And so that's part of why I wrote Recovery, and one of the reasons why I'm excited to be talking about what happens in the United States, where market forces do have just a little bit of room to breathe.
That thing about destroying the evidence, we see that in Denmark too, right? Like,
yeah. You can say so. But if you look at healthcare, and as we talked about a little earlier, there are a lot of similar problems in the Danish healthcare sector and the US healthcare sector. If you go back to the start of health economists, the 1963 article by Arrow, talking about the asymmetric information and adverse selection. So the fundamental problem that the customer don't decide his own demand of healthcare is a fundamental market failure problem, and it would always exist. So the interesting thing, how do you design a system that is coping best with it? And in Denmark, we have make the failure that we think because there is market failure, you can't use the market at all. The government has to take over, but there's also policy failures, or the public choice tradition, which we are very into. So they don't take into account all the policy failures. They think if the politicians get to decide what's about to do with the healthcare sector, you get the perfect system. Because you have to recognize that there are market failures, but it doesn't mean that you can't use the market at all to regulate the healthcare sector.
Because a market failure means that there are exchanges that would benefit both sides that are not happening. Yes. So that means every market failure you identify, the market has created incentives for someone to fix that, to correct that failure without government intervention. But the biggest myth, I think that you identified it, is surrounding all of these debates, is that only markets fail. Mm-hmm. Yeah. Government never does. Government is like some sort of nirvana. I mean, we all know that that's not true, but anytime anyone addresses the market, they will never compare its failures to government failures.
Yes.
That reminds me of when Michael Munger of Duke University was on the podcast. He said that we have to remember that government is quite capable of failing on its own. But anyway, the myth thing is interesting. Just a little comment from my side, listening to you guys talk, is that there's so many myths about the US system. There's also a lot of myths about the Danish system.
Yes.
And in fact, we are also suffering from it because we kept saying free when we're talking about it. We know it's not free. Yes. It's tax finance and so on. But it's so ingrained that even us who are trying to pull away the blanket of the myth, or whatever you want to say here, we also fall into these by just sheer use of language, these traps. It could actually be an interesting paper idea for you guys to have like the myth of the US system and the myth of the single, and then like compare them, because I think a lot of people benefit from that. I think that's interesting.
Yes. Probably the greatest myth about the Danish economy, the Danish system, as you might call it, as Karsten and I were discussing earlier, is that it is a socialist economy.
It's definitely not.
There is a prominent United States senator who seems to believe that it is.
Yeah.
His name is Bernie Sanders. And I would just like to note for the record that every year the Cato Institute puts out its Human Freedom Index, and Denmark this year, #1 slot.
Yeah. Exactly.
And very high on the economic freedom score, higher than the United States, I believe. So kudos. It's an honor to visit your country.
But speaking of not the devil, but Bernie Sanders, he actually recently wrote a piece in the Danish newspaper Politiken, where he was trying to beg Danes to pressure Novo Nordisk to lower its prices, or alternatively shame them into doing so. There were many issues with his points, and I was actually allowed to write the reply in the newspaper, which Danish listeners can look up. It's only in Danish. But he does have a couple of points I'd like you to comment on. So let's take them as we go along. So first of all, is he correct in saying that drugs like Wegovy will ruin the US?
No.
But that's his claim.
No. If anything ruins the U.S., it'll be the U.S. Congress.
Of which he is a member, right?
Yes. A drug is a tool, and Wegovy appears, by all accounts, I mean, we have to say appears because we have to collect more data. Yeah. This is a very complex question, but it appears to be a fantastic medication. And so it's a tool, and a very useful tool, and tools don't destroy things, humans destroy things. And if what Bernie Sanders means when he says that Wegovy could, or Ozempic could bankrupt the United States, is that Congress has set in motion so many policies that encourage overspending on drugs like these, excessive prices, excessive consumption, and taxpayer financing of those excessive prices and consumption. What he means is that Congress has messed up the healthcare sector in the United States so much that a wonderful, beneficial innovation could lead to much higher taxes, much more waste in the health sector, and that's all Congress's responsibility. That all we can lay the blame for all of that at Congress's feet, not anyone else's. Do you want to know why Novo Nordisk sets the prices for these medications so high, like $1,000 per month? It's because of the U.S. Congress, because the U.S. Congress floods the U.S. market with demand and encourages higher and higher prices. The Medicare program pays twice as much as for medications as other countries do on average. Novo Nordisk and other drug companies set their prices as high as they can so that they can get the highest possible price out of each payer, and in the highest or the least price sensitive payers are those in the United States, the employment-based plans and the Medicare program and even the Medicaid program. They can get wildly excessive prices out of these programs, so they set the prices really high, and that actually does, even though Novo Nordisk is a Danish company, that does encourage Danish and other drug companies around the world to invest in innovations like Wegovy and Ozempic. So there is an upside. But is it Novo Nordisk that's going to bankrupt the United States? Is it this wonderful new tool that's going to bankrupt the United States? No. Bernie Sanders needs to look inward, and he needs to do more work in Congress to restrain spending in the Medicare program and elsewhere in the U.S. health sector.
I'm glad you're confirming what I wrote in my reply to him. But if we try to take him a little bit, so I guess one of his points is saying that somehow it's better for humanity to give a discount now on drugs like Wegovy than use the profit to invest in innovations. Is there any merit in that argument?
Sure, because nobody knows what the optimal price for a drug should be.
Of course.
In theory, it is whatever produces the optimal level of pharmaceutical innovation, at least in a system where you use patents to try to embed the incentives for additional research and development in the prices of drugs. There are other sorts of systems. We've written about these at the Cato Institute, where the government could award prizes to innovators, so that's how they would recoup their investment. That would be the incentive to innovate. And then you would have free entry into the market for drugs. There'd be no patents, and all drugs would be marginal cost pricing. But there are a lot of problems with that system, but there are a lot of problems with the patent system as well. And one of them is that we might be getting excessive amounts of innovation right now. Innovation, the prices for drugs in the United States might be so high that they are encouraging low-value innovation that doesn't produce benefits in excess of costs. There's evidence to support that claim. And so it is not unreasonable to say that maybe prices shouldn't be as high. And if Bernie Sanders wants to try to shame companies into lowering their prices, he's free to do that. I mean, I believe in free speech, and shaming is a form of free speech. But is there merit to the idea that the prices should be lower? Maybe because, the U.S. Congress is pushing the prices too high right now, and no one really knows what the right price is.
Interesting. So another thing that I got from trying to understand where he was coming from was I think it's interesting that in the past socialists used to fight for the hungry and the poor, right? And now they apparently want to fight for the obese, right? So to what is there? And this actually points to a very interesting issue. And Karsten, please join in as well. Yes. Is that whose fault is it that you are obese? And is there limits to what we should think healthcare should cover? I mean, to the degree that you are at least partly responsible for some of your illnesses or your situation and so on, even though there's a drug that could help you, is that then something that is something we should require? And I think it's an interesting point, because if we go way back and read the left side of things, Rousseau even says that there's a limit to what he called physical inequality, because he lived in a time where there wasn't that much you could do if people were sick or whatever. Now there's a lot of stuff we can do. We have a big debate in Denmark about whether government should finance hormones for children who want to change their gender and so on. There was basically close to no limits as to what we can fund via healthcare systems. So how to deal with that issue? Like, should we just accept that whatever human illness can be fought with technology should be supported by either a single payer or a healthcare or an insurance system?
It's a difficult question. First of all, I think it's interesting to see how much is due to tradition or culture. In Denmark, we don't have free dentist care. Everything else is free. If you want to change your gender, you can get a dentist. But once you get your teeth, which is actually quite important for your health, then you have to pay, because it's a tradition in Denmark. You pay for your own teeth, so that's out of pocket money. So it has a lot to do with tradition. And then another point, I don't have the exact answer to your question, is that the Danish healthcare system, at least, is very bad at preventing illnesses, investing in preventing illnesses at any kind. And it's because the political problem is always the guys who are deathly sick here and now, in the present, because they are a problem. You can see them; they are there, and they are in the press and so on. And if you are investing in preventing illnesses, the return comes in many years, and then you might not be in office as a politician. And I think that's one of the key issues that a more insurance-based system could fix if you design it right. Mm-hmm. Because if you look there are other countries with insurance-based healthcare sectors, for example, Holland and Switzerland. You see a quite different approach to the long-term investments in care than you do in the Danish purely politician-driven healthcare system.
So move it away from policy towards pricing. Yeah.
First, something about obesity, and then about prevention. Yeah. I have absolutely zero interest in blaming or shaming anyone for being obese. I don't like treating obese people like they're some sort of other, like they're a problem, that they're creating a problem for society or anything like that. And that's one of the dangers of creating a government-run, a tax-financed system of healthcare is that, and all of a sudden, your behaviors are costing me money, and I don't really like your behaviors. And I have almost, a superficially plausible rationale to control your behavior. And I think that is one of the one of the worst parts of government financed healthcare is that it can lead to social tension or discord, where you have one group of people shaming another group of people for their decisions that only affect them. Having said that, a lot of people do struggle with obesity. And I think we should note here that before we even get to the question of insurance, that there has now been apparently some remarkable innovations to help with that issue. Again, we're talking about Wegovy and Ozempic and other drugs in that class. This is the market working. This is we don't need to have Bernie Sanders solve this problem with by tweaking the Medicare program this way or that, or the Medicaid or banning sugary sodas or anything like that. The market is finding ways to try to meet that need. So this is another argument in favor of markets. Whether health insurance should cover obesity treatment or not, I have no idea. That is something that we can leave to individuals and insurance companies in a competitive market, so we can figure out what is it that individual consumers want when it comes to preventing obesity or helping them lose weight. One thing that I think would help tremendously is, as Karsten suggested, if we had an insurance-based system where someone had an incentive to look out for your long-term health. We don't have that in the United States. As I mentioned, the government compels people to enroll in employer-sponsored insurance, and a typical U.S. worker changes jobs 12 times by the age of 52. So why would an insurer or an employer in the United States invest in prevention when the benefits are going to fall on someone else? So we've got that strike against the U.S. system, that you don't have the insurer doesn't have a lifetime relationship with the patient, so they don't have the incentive to make those investments in prevention that Karsten was talking about. But also, in the United States, as in most other countries, government efforts to establish universal government-run systems have blocked the sort of integrated health systems that have even greater incentives to invest in prevention. I mentioned before that in the United States, we have the Veterans Health Administration, and in the UK, they have the National Health Service. These are sort of anomalous because they are what we call fully integrated health delivery systems. But in the United States, we have a private sector one. It's called Kaiser Permanente. Again, the insurance company, the hospitals, the doctors, all the facilities, everything part of the same corporate entity. And as a result, they operate under different incentives where they internalize even more than other insurance companies do the cost of preventable diseases. So they have a greater incentive to cover cost-effective preventive care. And yet in almost every system, governments put in place subsidies or regulations that block that sort of innovation. And that in the United States, the only reason that Kaiser Permanente was able to survive was because Henry Kaiser was a billionaire who was able to use his wealth to overcome the regulatory obstacles that the government put in his way. And the government is still putting regulatory obstacles in the way of those plans, still penalizing them through the tax code, and still subsidizing the competition. And so even though in the United States, others are trying to create those plans, the government is suppressing them. We need to get the government to stop doing all of these things. And I think then we'll have the sort of emphasis on preventive care that Karsten was talking about.
Do you have anything to add?
Yeah, maybe. As I understood you, Michael, both the treatments and the insurance is integrated in the Kaiser Permanente. Yes. And I think that's very interesting because one of the fundamental problems is that when you go to the doctor, he decides what your demand for healthcare is, and then he gets in some kind of way money. through your demand, and maybe directly or maybe indirect through government grants or something like that. But that's, as I see it, the main reason that we have this overproduction, where around 20 to 30% of all treatments are pure waste in both in nearly every healthcare system that you got. And when I look around Europe and through the Dutch system, and especially the system they have in Switzerland, the insurance companies and the treatment facilities are not integrated, but the insurance companies play a very important role in controlling the supply side by using data, looking at the costs of different elderly care homes, different doctors who run clinics, saying you are prescribing too many drugs, your treatments are too expensive compared to another doctor with a similar kind of patients, and by that way controlling the costs, but also given an incentive to invest in preventing illnesses, giving more care in the start of when you're starting to get sick, or if an elderly person falls and break their arm, then it might be a good thing to give a lot of care in the beginning of the process, because then they can maybe get all well. If you don't do that, maybe they'll have a disability for the rest of their lives. And that kind of investment is actually given a price in that system, because you can invest as a doctor or a elderly care home, and then you can get the return. And that's I see is very interesting if you have to cure the healthcare sector in Denmark, but maybe also in the US.
So speaking of cure, Mike, your book Recovery, which is a very interesting read. Everybody should give it some time. It's not that long, so it's everybody can get through it. You suggest some fixes, and we have touched on some of the issues here. But let's just, what is working, what is not working, your healthcare, and what is then the recovery of what is not working? Can you sort of sum up the arguments?
So what works is when you leave people free to experiment with different innovations in health insurance, different innovations in healthcare delivery, different innovations in pharmaceuticals, and leave consumers free to choose between all these different options. And that doesn't just mean tear down regulatory barriers. It also means let them spend their own money the way that they want. I mean, the book really proceeds from a few simple premises. One is that we do have rights when it comes to our healthcare. The most important is the right to make our own health decisions. That is a fundamental human right. And when government regulates or taxes, then it is infringing on that fundamental human right. But when government respects that right, markets, as a matter of course, just make healthcare more universal by driving down prices with quality innovations, that all of which fill in the gaps of the health sector so that fewer people fall through today than fell through yesterday. And the book focuses largely on the United States and makes recommendations within a U.S. context, but a lot of them apply to foreign systems as well. For example, if you wanted to reform the Danish health sector, one way that you could do that is you could, instead of sending money from the national government out to the regions, you could use some of the programs that other countries such as the United States, Switzerland, the Netherlands use to come up with a risk-adjusted amount that those systems pay insurance companies to cover residents. A risk-adjusted amount means that if you have an expensive illness, you get a bigger check from the government, or they write a bigger check on your behalf. Those programs basically come up with a subsidy that is based on your disease burden. And once they have the capacity to do that, there's no reason not to just give that money to the consumer and then free insurance companies to innovate in all sorts of ways, including in pricing, so that if you have diabetes, they can charge you a higher premium. But you know what? You'd be getting a bigger check from the government. Mm-hmm. So you would be able to afford that higher premium. if you do that, then the insurance companies will be able to innovate on the dimensions that we've been talking about, including making healthcare more secure for people once they get sick. And you can do that and take advantage of the market while still having redistribution. That's the myth of the Danish economy, or at least Bernie Sanders' myth about the Danish economy, is that because you have redistribution, you don't have markets. You can have redistribution and have markets in healthcare as well. And the book, specifically the Medicare chapter of the book, gives recommendations that could apply to Denmark.
Very interesting. And I think that innovation and that personal choice is so important, because a big issue with the Danish system is that it's one fits all solutions all the way through. And that is simply not how healthcare works for people. Every journey is individual when you get sick, right? I mean, there are similarities, but the fact that everybody has to get the same treatment all the time because that's what's been decided is hurting consumers.
Yeah, and an interesting point here is people aren't getting the same treatment. We have a myth in Denmark where we think that because we have a tax-financed system, it creates equality. And that's a lie. There's been a huge amount of research showing that if you are an attorney and you have a drinking problem and maybe you got some liver cancer and you go to the hospital, you get better treatment than someone who's a truck driver and have exact the same disease. And you get even better treatment if you're a doctor or a nurse, then you know the system and you know how to work the system. The Soviet Union wasn't an equal system either, and that's very interesting because they don't get the same treatment. And actually, there's some research from the University of Copenhagen showing that they shouldn't get the same treatment. The background of the doctor is actually crucial to which treatment people get. If the doctor has a working class background, he's better at treating working class people, actually, because he understands and he can communicate with them than a guy who doesn't have a working class background. So all this Danish myth about equality is interesting, and it's a lie.
That's what we call cultural literacy.
Yes.
Yeah.
Yes.
Yes. So we're coming up on time now, but I do have one last provocative question before we finish this. This will be proactive, at least to Danes, but I'd like to hear you. So you have already, as I promised the listener in the beginning, you already taught me a lot during this lesson, or this talk, sorry. But let's see here how I respond to this. So you are critical of the need for state licensing of medical professionals. Please explain that, because I think that is a revolutionary thought today.
Because government licensing of clinicians, even though the purpose is to, the stated purpose anyway, is to improve the quality of care, it has the opposite effect. Mm-hmm. And along the way, it also increases prices. So how the division of labor works in healthcare is much like in other areas of the economy, where entrepreneurs see an opportunity to provide a service at a lower cost. They will train someone with less with less education to perform that service. I believe here you have, like we have in the United States, dental hygienists. The idea of a dental hygienist occurred to a Connecticut physician in the 1920s. He trained some of his staff to do basic cleanings, and a health profession was born. That made dental care more affordable. If we only had dentists, and only dentists could do teeth cleanings, then everybody's teeth everywhere would be much worse. So what happens though is once markets are constantly doing this, I could tell the story of dental therapists and people inventing that profession in New Zealand around the same time. And this is how markets constantly make healthcare more affordable, by enabling people with less training and less, let's be honest, student loan debt, to provide services at a lower price. And that makes healthcare more affordable and more universal. And once they do that, they also develop, entrepreneurs also develop their own quality standards for these professions. And in case those quality standards aren't good enough, you do have government there to come to the aid of anyone whom one of these clinicians might have harmed through negligence. So there are also those protections as well. and healthcare becomes more universal. But when the government steps in and begins licensing these professions, then you can only create a new clinician category. You can only what we call right skill those tasks if you get permission from the government. And who controls the government's power here? Well, it's usually the dentists, or it's usually the physicians who have excessive or inordinate amount of influence over whether the government says that nurse practitioners can practice independently or can prescribe medications. And so we don't get this constant process of driving prices down. But the worst part, and that makes healthcare less universal. But the worst part to my mind about clinician licensing is that it is the primary barrier to those sorts of integrated health systems that I mentioned that focus on prevention, that innovate in the area of electronic medical records. Kaiser Permanente has been using electronic health records since the 1960s, as soon as there were computers, because they have unique incentives to do that. They do research that improves the quality of care and shows how to make healthcare less expensive and more universal. And in the book, I talk about how Kaiser Permanente even found an unsafe drug faster than the U.S. Food and Drug Administration did. That was Vioxx about 20 years ago. So Kaiser even beat the government at its own game there. But clinician regulation or clinician licensing has blocked the spread of those sorts of plans across the United States to the detriment of consumers.
Yeah, I agree. The professions, physicians, and also nurses actually use the licensing to protect their own monopoly. It's also a big problem in Denmark. But then again, if you get a totally free market, you then have the asymmetric information problem that if you go to a doctor or a dentist or anything, and he's not capable of doing what he's promising you that he can cure you. He's going to cure cancer by massaging your aura or anything like that. Then you can reverse the decision. If you get a bad pizza, you can go to another restaurant, but you can reverse that decision. So I think here again the solution might be to take the licensing away from the government and then leave it to the insurance companies, because they have a long-term reputation to protect. If other people know, if you go to that insurance company, you get bad treatment because they are licensing someone who's not able of doing that, then they will lose money, and they don't have the incentive to do so. But then again, they also want to deliver the most cost-effective products to their customers. So I think it will be the best solutions to actually place the licensing decision at the companies and not at the individual consumer.
I think that's right, and I think that's how it would develop naturally in a free market, because a large integrated system like Kaiser Permanente would invest in the health records that would tell them who's practicing safe and high quality medicine.
Exactly.
And so they would have the ability to make those judgments about individual clinicians, and a tremendous incentive to do it, not just because of the competitive market pressures. In other words, that insurance company has lousy doctors, I'm not going there. Yeah. But people are much more willing to sue large corporations than they are to sue individual physicians. Trial lawyers are much more willing to take on those cases because the large corporations are much more heavily insured. So their incentives to engage in that sort of quality measurement, quality control are much greater. And that, in my guess is, no one ever really knows how a market will develop, but my guess is that is how markets would provide the quality assurance that government is trying and failing to provide through clinician licensing.
Cool. Very interesting. So to brush up, I'd just like to, as I have been listening to this conversation, which I found was very educational, it's very interesting that aiming for universalism in healthcare is actually a pricing issue. It's actually a matter of making it as affordable as possible. That is the best way to ensure universalism, rather than through political means. And I think, at least for Danish people, that would be a revolutionary thought. That's a very interesting point. So thank you very much. I'd like to make one point before I end it, that some of your listeners might have heard us laughing a lot today, and that might be a little bit in poor taste, because, as Michael very clearly point out we are dealing with real people here with real serious issues. But what we're laughing at is obviously not the issues behind people who seek medical attention, but rather the fact that this system is utterly absurd. And it is particularly absurd because it's a result of human decisions, and we can change that as human beings. This is one of the reasons why economics is such a great science, is because it teaches us the science of human action. So when we're laughing at the absurdity of humanity, not at people.
It reminds me of a legendary episode of the comic series Yes Minister, where there's a hospital who wins the prize of the best driven hospital in all the UK because it has no patients. It's the perfect hospital. Everything is functioning so well, but it has no patients because they couldn't afford to get the patient once the hospital was built. The costs were too high.
Their medical error rate was zero, or almost zero.
Exactly. So I just like to point that out. So thank you for your time, dear listeners. And thank you to you, Michael. It was very interesting indeed. Thank you so much.
Thank you for having me.
As mentioned in the beginning by Karsten, we do have a competition. So the first 5 people to write an email with their postal address and the word recovery in the subject line to Kim@Cepos, that is KIM at Cepos, will get a free copy of Michael's short but interesting book. Will you autograph it for them, Michael? Could you do
Certainly.
It? Lovely. Let's do that. Well, with that, thank you very much, and stay rational, people.
Tak for, at du lyttede med til Rig på Viden. Jeg håber, at du lærte noget, og hvis du nu synes godt af vores podcast, så kan du støtte os ved at følge den på Spotify eller skrive en anbefaling på iTunes. Inde på LinkedIn, der kan du følge André Thormand, Benjamin Somofen eller Henrik Fode Rasmussen. På genhør.